after all, you live with this and you know what's worked for you. And sometimes it's just nice, I think, from one patient to hear from another what sort of things have helped them. So without further ado, I'll just start by asking Dr. Nguyen maybe to introduce himself, and then maybe we can just move down the line and hear a little bit about who our panelists are and sort of what their roles are.
Hi, everybody. My name is Nguyen. I am an optometrist at the Emory Healthcare Center, and I practice primary HK at Emory Midtown.
Hello, my name is Tracy Schaffer. I'm actually a nurse in Utah. I don't live here in Georgia. I'm a clinical nurse that works, I know Dr. Clardy's name has been kind of thrown out there quite a bit, but I'm a clinical nurse that works with Dr. Clardy in the neuroimmunology department at the U.
My name's Enoch. I'm one of the pediatric physiatrists over at Children's Healthcare Atlanta, board certified in adult rehabilitation medicine as well as in pediatrics.
Now you're not. No, I was helping everybody else and mine doesn't work. How about that? I'm Dr. Yuri Shishido. I am a clinical, actually pediatric neuropsychologist, and I work with children with complex medical conditions, especially in neuroimmunology conditions. And my job really is to evaluate how the medical conditions impact children's cognitive development and everyday functioning and help families with treatment plan.
Hi, my name is Gwen Carr. I work for Children's Healthcare of Atlanta. I am a program coordinator for neuroimmunology.
Okay, so as you have all heard, we have a very interesting and diverse group of people participating in this panel. And so maybe you have never even met the kinds of people who are up on stage, which I think is really cool. And it's great to be able to realize who else can help besides a neurologist. And so it's really wonderful to see the resources kind of available and to hear a little bit more from them. So why don't we just start with some of the common symptoms that patients with NMO and MOGAD face. We talk a lot about attacks. We talk a lot about the immunology of the attacks. Sometimes the actual inflammation itself will resolve, but may continue to experience symptoms beyond that. And so I guess I would just actually, open it up with whoever would like to start. What are some of the symptoms that you have helped patients with NMO and MOGAD work through?
Sure. So I practice primarily covering the ophthalmology consult service at Emory Midtown. So very oftentimes patients actually will present with an episode with vision loss or eye pain. And, we're really oftentimes the first providers that diagnose this condition. We kind of work alongside very closely with our other ophthalmologists, especially our neuro-ophthalmology team and the neurology team in the hospital to help these patients. Status post-attacks, when patients are diagnosed and treated, very oftentimes patients will have, chronic vision loss or blurry vision that needs to be managed. And so as primary eye care providers, what we do is we actually can help patients see better and function better with the vision that they do have. And so within the realm of optometry, we actually have dedicated professionals, what we call low vision providers, that work with patients who have lost vision. And so they don't necessarily bring your vision back, but they actually help you become more independent. And we take a very, in multidisciplinary approach to helping patients live more independent lives. And so we work very closely with occupational therapists, physical therapists to allow our patients to see better. For those patients who have lost a lot of their vision and are considered legally blind as well, we actually do work very closely with our blind rehab specialists, helping them adapt to their new life with the vision that they have. And in addition, some patients also will have double vision as a permanent sequelae from their NMO or MOGAD, and sometimes we can actually help that double vision, whether that be in the form of glasses prescription with prismatic correction in it, or we may also help coordinate referrals to surgeons who can actually realign the eyes if you have misaligned eyes from this condition.
That's perfect. So I think it sounds like there are a lot of options for, after the initial attack. One of the other follow-up questions I have for you is I'm curious about some patients will note that they have continued eye pain, sometimes even after an attack ends, and I've always found that very interesting. Of course, ocular pain, particularly with movement, is oftentimes sort of a harbinger of a future attack of optic neuritis. And is that something that you've seen in your practice, that patients will continue to feel some degree of discomfort after the attack ends, and what sort of things might be helpful for that?
Right. So, unfortunately, this is actually quite common, and the concern for these patients is that are they having another flare up? And it can be kind of difficult to distinguish between, an acute presentation versus, a subacute on chronic presentation for these patients. But our main job is to make sure they're not having another active attack that's damaging their vision that we can prevent and treat. But for those patients, who endorse, eye pain, following these attacks, unfortunately, we don't have too much in our toolbox to help with the pain. A lot of the times, we also wonder if eye pain is very non-specific. So you can have eye pain from lots of different reasons. It could, the most common source of eye pain is actually a headache, and so sometimes we wonder if if there's kind of another process going on that's involved with the eye pain, and so we help distinguish that based on our examination, as well as helping coordinate referrals to our colleagues as well.
Dr. Shishido, we have touched briefly about the role of neuropsychological testing, and especially the role that it has played in the pediatric population. I'm just curious, since you're here and you are a very rare breed, I will say, and this is maybe even the first time that many people in the room have met a neuropsychologist or perhaps ever even heard of one. And so I'm curious if you will just explain to us a little bit about, what is your role, what is the purpose and the potential benefits of testing, and then if you could comment on, cognitive symptoms that you have seen in patients with these disorders and what can be helpful for that.
Great question. I still am trying to explain what I do to my family, and they haven't gotten it. So I'm going to try my best here. So we talked about the research and lack thereof for pediatric. And if you think about that in an overall medical population, there is just even much less research done from pediatric neuropsychology. Having said that, there are emerging research that's really showing that children with the NMO as well as MOGAD are at risk for some level of cognitive difficulties. And research, and as well as my clinical experience, you are talking about the range of symptoms, starting with attention, processing speed, executive functioning, which includes things like a working memory, planning and organizing. It can be visual and motor, given that vision symptomatology. And all of these, if you think about it, that impacts children's learning and their everyday functioning, as well as emotional. That somebody talked about the mood, I think in that table, that all of that is part of my evaluation. And so what neuropsychological evaluation does is to really help me describe everyone's strength and weakness in learning. Now, children learn differently. And I think that will give me more information about how I can leverage strength as well as to support different kind of, or generate different recommendations to help area of weakness so that they can more easily go back to school. I think I heard that needs, and things like that.
Perfect. So I practice mostly in the hospital, and I have to say I greatly admire the work that's done by our physiatry colleagues and our teammates in physical medicine and rehabilitation. And so I would just like to call on Dr. Leung to kind of guide us through a little bit about what are some of the things that people can expect after they experience a attack. What does the road to recovery look like in terms of helping to manage some of the physical manifestations that sort of set in after an attack?
I think Dr. Nguyen and Dr. Shishido had kind of touched on a lot of things, especially at our practice at Children's Healthcare Atlanta. I think we see the spectrum in terms of severity, from the mildest to the most severe. And part of the population we see at Children's, especially the ones with severe instances, do come onto our acute inpatient rehab unit. And that's where they work with what Dr. Nguyen had mentioned, the physical therapists, occupational therapists, and speech therapy staff, just to redevelop some of the abilities that some of these attacks may have kind of taken away. And also kind of on the unit that we do have neuropsychology that's in-house as well to then work with the school teachers to, again, reestablish that quality of life that our patients kind of need. And so pending kind of the severity, there's a spectrum and range of how long they'll typically stay with us. Most of the patients that we see are of school age, so a lot of times our recommendation for the next step is to move on to our day rehab program, which is more of a school reintegration program for our patients so that they can continue to learn how to care for themselves. And I think the biggest piece that we offer as a physiatrist is that quality of life piece. We want everyone to be able to go back to the life that they were having. And depending on what their needs are from the evaluations from individuals like Dr. Nguyen, Dr. Shishido, and Dr. Kanan, and Dr. Gombolay, is moving forward and developing a plan so that that independence is maintained. And certainly all of us in physiatry, we continue to follow these patients because we see more just beyond the physical, occupational, and speech component. A lot of times our patients are affected by issues with bowel and bladder. There's tone and spasticity and certain deficits that may require additional needs like bracing and durable medical equipment. So that's kind of what we do as physiatrists is look at the whole picture and kind of provide the best quality of life that we can.
We've talked a lot about, I think, the visual manifestations of both disorders and the impact that it can kind of have. And I really appreciate the point about spasticity. And so, both of these disorders can affect the spinal cord, and oftentimes that will lead to increased tone or a stiffness of the muscles in the portions of the body that kind of ascribe to where that lesion might be located. And so I'm curious, can you talk or share a little bit about what are some of the things that you use to manage spasticity? To what are the options available to patients?
So in regards to spasticity management, I think the way I usually phrase it to parents and patients and families is that the brain now has a harder time kind of turning off the signaling to turn off muscle activity. So in essence, what we do is try to tone down dose signaling, and whether it be more oral medications that you take versus potentially injections with botulinum toxin. Those are some of the options that we provide. And more recently, what we've been doing is what we call cryoneurotomy, which is, again, dampening that signaling to muscles that are essentially overactive to then help with certain day-to-day things, because we understand that spasticity comes in many different forms. Some of it can be beneficial. Other times it is detrimental. And I think the thing that I always tell patients is if spasticity is severe enough, it almost feels like all of us having a Charlie horse. That doesn't really go away. And so management of that is definitely important. And not only does it really manifest sort of in muscles and extremities that we can see, but also in other areas that we may not, such as in the bladder and things like that. So that's why we try to formulate more of a comprehensive plan to manage spasticity.
Thank you. So, Ms. Schaffer, I have to say it's really a pleasure having you here. One of the great things about, I think, having the summer conference in autoimmune neurology in Atlanta is to also hear a lot from our colleagues about how they do things in their environment. And so we can sometimes evaluate what we're doing and see if there are better ways of doing things. And so I'm curious if you would expand a little bit on your role and how you work with, folks like Dr. Clardy and how you interact with patients in their clinic.
So great question. In our clinic, I actually work with 6 different providers, and most all of them do neuroimmunology in our clinic. But a lot of what I do is I would say more patient advocacy. And when I say that, I'm the one behind the scenes. I'm not always in the rooms with the patients. but I'm the one who's there advocating for a new wheelchair when the insurance companies are denying it. I'm the one who's trying to get your drugs approved when the insurance companies are denying it. So I'm really the one who's kind of behind the scenes. I also like to get involved, especially with our new patients, to go in and meet with them, and just so people know who I am. In our system at the U, what we do a lot of, and maybe it's the same here, is what we call my chart. So patients can message their providers, but I'm the one who triages every single message that comes through. I really try and get to know my patients and have a relationship with them. And I kind of describe it as a more intimate relationship than what the providers actually have. I know when something's going on with them before the provider does. Maybe they just recently got married. I'm the one who's telling the provider, like, hey, when you go see this patient, just so you know, they just got married. Or, different things like that, that maybe the provider doesn't have that type of relationship. So that's really what my job is. And then the patient education. I mean, when you are newly diagnosed with some of these diseases, it's a lot of information thrown at you all at once. And so I'm kind of that one who can meet with them at a later time and just kind of discuss, like, this is what this all means, and this is what we can do for you.
Perfect. Thank you for sharing that. So now we will turn to the famous Miss Carr, who actually I feel a lot of people in the room probably know. But Miss Carr, I will just ask you to share a little bit about your role as the clinic coordinator for the pediatric neuroimmunology program. I think that's a relative, recent thing. It's been a nice invention on the part of the CHOA group to have you there holding it all together as the glue. And so will you share with us a little bit about that and how patients can best access you and what sort of role you play?
I'm almost embarrassed now. So the neuroscience program coordinator is a fairly new position they created about 3 years ago, and I interviewed for it and got it. So when I actually took the position, I was like, so what do you want me to do? They're like, okay, make neurosciences better. So basically my first thing is like everything when we're trying to investigate, where are the problems? One of our biggest problems that I saw was that our children, once the physicians had written orders for their disease modifying treatments, seemed to come to a stop there. Nurses did not know where to go about sending these kids to get their infusions. They sent them to the infusion center. That was probably the easiest thing. They sent them to home care. They knew nothing about what happened from that point on. So I had to gather our patients together. I started finding out that there was no real training for how to move these orders forward. For instance, if a nurse had gotten a denial from the insurance company stating, no, we don't want this kid to have this drug. Some were like, okay, kid can't have drug. No, that's, I had to learn. I learned, believe it or not, from everybody from home infusion companies to the infusion center to the insurance companies themselves, how to manage this crazy world of getting approvals for these medications and getting them quickly. So I work very closely with our doctors. They've taught me a lot. Oh my gosh. But the minute they write an order, I'm on it. I've got to have these kids to where they're getting their treatments within 2 weeks. That's my goal. And, I just wish that more facilities, more healthcare systems had program coordinators who can actually bridge that gap. Someone who's actually working closely with the doctor themselves, but learns all of the bits and pieces that nobody really is taught to do. So
We have talked a lot about, I think, physical health, and I want us to all leave with the impression today that we really have to take care of the whole person as part of the management of this disorder. And so I wanted to ask Dr. Shishido to expand a little bit upon what are some of the resources for mental health in the local community. I know some of your work helps to identify that these are areas that need to be addressed alongside, some of the physical symptoms that people have. And so just wanted to, see what your thoughts are on that.
Thank you for that question. I think that's a great question because even though my focus is on more cognitive and thinking skills, but emotional functioning is so important because if you're not feeling well, you're not going to pay attention. You're not going to be able to process the information quickly. So taking care of both your cognitive as well as emotional and physical, to that matter, functioning are very important. And if you have a chance to complete neuropsychological evaluation, we definitely look at that and we customize, tailored approach to individual needs. And one of the things that we always check is emotional functioning, anxiety, depression, adjustments, because you just had a diagnosis. And I work very closely with our behavioral health, mental health organization, and we have a quick referral process for the both either the medication management as well as therapies, the range of therapies available, as well as we have a pretty good resource that's being updated every 3 months within our behavioral mental health that captures a list of available resources, therapists and different kind of cognitive behavioral therapy and a different kind of therapists available by county that I tap and share with. So.
Perfect. Thank you so much. And then, Dr. Leung, I wanted to ask you about, a lot of patients, I think, experience pain. Sometimes they experience paroxysmal spasms as a part of the dealing with their disorders or recovering from attacks of myelitis. And so I just wanted to hear a little bit about some of the options for managing pain or paroxysmal spasms. Have you had much experience with that in helping patients?
I think we see that more often than we actually want to recognize, and I think it's something we manage quite frequently in our practice, and especially from patients we've seen from our inpatient unit. And certainly, medications is probably one of the things that we would always consider, but there are definitely other modalities that we try to rely on. And that mainly comes from our therapy staff, whether it be more from a physical therapy or an occupational therapist. They can implement other sort of techniques that help with spasms and overall pain in general, whether that be kind of tissue mobilization and massages, or even implementing other modalities such as aquatics, which is, for some may cause worsening, but at other times they may be helpful and beneficial in some of their pain. We also work very closely with our pain team as well with other sort of interventions. I know I've had some patients who've had success with other modalities such as acupuncture and things like that. So again, there's a lot out there that we can potentially have access to, especially to make comfort one of the biggest things.
And then I wanted to ask Ms. Schaffer and Ms. Carr to kind of give us an idea. So we're fortunate here that I think, we have representation from optometry and physiatry and neuropsychology. And we heard from many of the patients who are the people on their healthcare team previously. But I also, since Ms. Carr and Ms. Schaffer have a firsthand experience of how to connect patients with other members of the healthcare community, what sort of other providers are your patients seeing, and how are they connected to them?
At the U, we're very fortunate to have pretty much every different type of healthcare provider that's out there. So anytime that we recognize, and a lot of times that'll be something that I can recognize just talking with the patient, we can get those patients set up with whatever they need. In our particular clinic, for example, we do have access to a pharmacist, a clinical pharmacist, that's right there. We have access to social work. But it really depends on what's going on with the patient, and then we can connect them. Most of the time, our providers just allow as nurses to place those referrals if it is something that we identify right away. So we can place those referrals and then help that patient navigate or the family navigate whatever it is that they need.
I have to say, the people on this stage with me are kind of the backbone sometimes of helping us along with treatment of our patients. I will say that a lot of our kids are getting infusions, so I have specific outside agencies that I use if they need home care for infusions. I have connections within our own infusion center. I've gotten to know the people that are going to support our children. But it's very passionate to me that they get the best care possible. But the one thing that I try to do is to keep patient family centered care at the center of things. It's not a cookie cutter process. Not every kid needs to go to the infusion center. They may live miles away. They may be headed to college in another state. They may be looking for a job on Wall Street. I don't want them to have any limits, so I will set them with home care if that's good for them. There are kids that you think, well, they would want to go to home care, but parents go, no, we have dogs. Little siblings will rip the IVs out. We have kids that we want to keep a close eye on because we've noticed that, we keep getting calls from home care stating, oh, well, they've canceled 3 infusions in the past. So a lot of what I do is trying to decide what is best for each individual patient, not necessarily just the patient, it's the whole family unit. So this affects not only the kid, it affects the parents, it affects the siblings. So the decisions that I make have to involve the whole entire family and what's best for them.
I wanted to kind of off of what you said, Gwen. One of the important things as a nurse is we need to remember, and I think as all healthcare professionals, is we need to remember the patient and the family has a voice too. So just because we might recommend something, if you've worked with, say, like a home health agency, an infusion company, whatever it is, we're going to ask that. That's going to be one of the first questions that I always ask. Have you worked with somebody in the past that you would prefer to continue working with? And if you haven't and you come back to us and say, I have not, but can you recommend somebody? Then we will do some recommendations. But you definitely have a voice, and so make sure that you're using that.
Perfect. So now I just want to switch gears instead of calling people out individually. If you all want to jump in as you feel inclined. I know one of the questions that I sometimes get in the hospital setting when everything is brand new and there are many questions is there anything that the patient can be doing if it's an adjustment in lifestyle, what they eat, how they exercise, how they sleep, just general tips for wellness, things that they can modify themselves at home. Do any of you have any recommendations or thoughts about that?
Take that one. A lot of our patients are teenagers. What do teenagers tend to do nowadays? They hold that cell phone in their hand. One of the first questions that we ask them is, are you sleeping at night? Almost 50% of the time say, no, I have a hard time going to sleep. This is where Dr. Gombolay starts doing her notes because I'll take over. It's like you've got to put that phone down at least an hour before going to bed. Those sort of things you don't even find. I mean, how to eat right, how to exercise, things of that nature. But, we have to teach our kids how to take care of themselves and how some of the things that are normal for them may not be actually good for them. So, it's easy to tell them not to eat ice cream and eat a low-fat diet and, get 30 minutes of exercise. But then sometimes you have to get down to what they actually may have as barriers.
I would like to piggyback on that. So, as an eye care provider, patients will have a variety of different complaints, but a lot of it does have to do with lifestyle. And so I think, when you're spending hours of your day on the computer, on your phone, there are implications in terms of eye symptoms. Patients will develop eye strain, eye fatigue, dry eye, which is, I'm sure everyone experiences at some point. But in the context of patients who've had, attacks that has affected their vision and caused them eye pain, we want to find ways to kind of reduce all the, potential factors that may be causing discomfort in your life. And so I think that just being mindful of the activities that you're doing and then trying to take a proactive approach about trying to limit your screen use using, drops, even though sometimes it can be annoying or easy to forget. These tend to actually make a really big difference in patients' symptoms and their quality of life.
I would be remiss not to add that to how the sleep and lifestyle impacts your thinking skills. I sometimes have children who are yawning, and I ask questions. What time did you go to sleep? Did you eat breakfast? Oh, I was playing game with my friends until what time is it? Was it really like 2:00? Of course, you're not going to be able to pay attention. And so it's really important for both physical, emotional, and cognitive health to have a structure. And it's not just for children, by the way, parents. We all do need to have a set time to go to bed, right? Turn off our smartphones 1 hour before, right? And so those kind of things are quite simple, but we can all do to encourage our children as well as all of our thinking skills and all mental health as well.
It's important for all of us.
I was about to say, I feel like I'm learning some stuff myself, and perhaps I can fix my own sleep and therefore improve my concentration the next day. I think our last question for the panel before kind of we open up to the audience is just caring for the caregiver. And so are there some strategies that you all have shared with patients and their families about, we have to make sure that our team is also cared for and they're in good shape so they can help with patients. And so are there some things that you all share with patients and families in that respect?
I can take that one. One of the things that I always tell the caregiver is to remember yourself. I mean, your life becomes, it seems like in the beginning, doctor's appointments and taking care of that patient. But take time for yourself. Make sure that you're asking for help. Accept the help that comes to you. People are great about, volunteering to come over and spend time with you and your loved one. And another thing that I like to kind of advocate for is sometimes we can set up as nurses home health to come into the home and for there actually to kind of coordinate where there might be an aide or somebody in the home while you maybe go do your shopping or go to lunch or something like that. So take advantage of those different opportunities that are out there. But the big thing is taking time for yourself. And then if you feel that you need, some brain health, I call it your brain health, where you might need to talk to somebody, there's no shame in asking for that too, because you need to take care of yourself in order to take care of your loved one.
Yeah, I would add to what Ms. Schaffer's saying, because I think, especially with the patients that we see at CHOA, sometimes family forget that ultimately who they are family. And I think they overarch themselves a little too much sometimes, and that in essence wears them out. And so for moms and dads, I typically at some point will say, your biggest role is to be their mom, their dad, and that let the medical staff and the medical team take over some of your worries so that you do have that separation so that you can continue to love them the way that a mom and a dad would, and not burn yourselves out by worrying about extraneous things. And the other piece, like Ms. Schaffer says, there's always someone you can talk to. And I think at some point everyone sort of forgets about that because in a circumstance like this, you're not the only one. And there's many others that you can rely on, and in the future you may be that person that another family may rely on as well.
I would say, yeah, like finding a community where you can share your feelings and your experiences with other people that have kind of gone through the same situation. I see a lot of caregivers who are become their primary drivers and responsible for bringing their loved ones to all their appointments, and it takes a lot of out of their lives as well. And so I think finding the right people in your life where you can you feel comfortable to share your personal feelings about that extreme amount of responsibility that you've kind of inherited could be helpful.
So this has been a very wonderful day, and we have 10 minutes left, I think, or approximately. And so I'm curious if there are questions in the room, if anybody would like to pose to the panel.
First of all, thank you. And I do wanted to ask for some of our patients who live in more of the underserved area or more rural area who doesn't have the advantage of having such a great multidisciplinary team. What kind of suggestions would you give them for self-care?
I feel like I'm answering all the questions. Sorry. So most of my career actually was in rural healthcare. In fact, I spent about 23 years in rural healthcare. So I know the lack of access that's out there and that's not available for a lot of patients. But since I actually moved up to the University of Utah, I kind of got a different perspective on things. There's still resources out there. And I know we talk a lot about COVID and, a lot that happened. But with COVID, one of the things that we did find is that there's so much accessible through like Zoom, Zoom calls or Teams or whatever platform you're using. To get online. I know a lot of our providers even actually offer online appointments for some of our patients that are further away from our clinic area. So check into what resources are available out there in your community. I know I was actually at the AAN conference this past couple days, but there's home health companies that will come out and, offer infusions to these different patients out at your home. So it's not like you have to go to these infusion centers that are 3 and 4 hours away from your home. So check with your provider, check with your nurse. We actually do know a lot of the resources out there, and let's see if we can get you set up for some of those different things that are available to you.
Yes, hi. So I had a very severe relapse in 2019 where I was paralyzed from the neck down. I was intubated for nearly a month. And so I went through the process of healing and trying to get back to my quality of life before that relapse. So that was physical occupational therapy and, relearning how to swallow food. But at some point, I felt like I was really frustrated that I may be putting too much strain on my body trying to get back to normal. And when really what I needed was to probably just to rest and give my body the proper time to heal. So I wanted to ask if there's an approach maybe that you take when you're trying to decide what is the best plan to treat these symptoms and how much of it is, okay, you do need time to just let your body heal, and how much of it active therapy to try to get back to that quality of life.
So we've definitely seen, even personally, a lot of patients who are in your similar circumstance where you feel like you almost plateau at some point. And more often than not, I think our recommendation is to give yourself a break. And a lot of times, just like all of us, by doing too much of one thing at one point will overall tax your body physically, mentally, and emotionally. A lot of times, it's very helpful to identify other things that you may enjoy and have just a change of scenery so that you have that ability to re-energize yourself and then immerse yourself into getting stronger and better thereafter. Because I do realize that it's not possible for all of us to be on 24/7, 7 days a week. This is why we have weekends, right? So even the kids that have been on our rehab unit, for as much therapy as they do, their weekend days are typically the lighter days, so that they do have the opportunity to recover, to re-energize. And certainly from an outpatient therapy standpoint, what I typically like to do is, if the drive is there, to even change up the type of modality of therapies, where, because I think a lot of us experience, I think, rehab fatigue. That's kind of what I say. That you're doing the same thing over and over again. And just like we're learning the same thing over and over again, there's only so much you can do. And so I think myself and my partners, more often than not, will recommend saying either taking a break and then just re-immersing yourself in different types of activities, different types of therapies to kind of give your body that break.
So this may be the last question we have time for, but we often survey our patients. We recently surveyed our patient community around the biggest symptoms they contend with daily that are a real challenge for them. We touched on the number one issue, which is chronic pain. An overwhelming majority of NMOSD and MOGAD patients can live with chronic pain most of the time, even some of them all of the time. So we touched on that, but the other ones that came up, and I'll open it up to the panel. Any thoughts? Fatigue was a huge one. Brain fog was another. Anxiety and incontinence. And where would you point patients to on those particular issues? Just briefly. Thank you.
I'll start. I think from a fatigue standpoint, again, to a certain extent, I think we may be overextending ourselves to cause that physical, emotional, and mental fatigue. There's certainly medications that we try. I think Dr. Gombolay and Dr. Kanan, with neurology, also have kind of the resources for that. And so certainly those are things we definitely consider, especially for patients that are complaining of fatigue. Other things such as incontinence, we work closely with our urology colleagues, especially. In the community, there are also physical therapists that are well-versed in things like pelvic floor therapy that we often refer to as well. So I think, from a broadly put perspective, I think all of us are here because we all rely on others to help all of our patients and all of their care. So
I will take the brain fog because I hear that often from my patients. So the brain fog is a subjective experience of that I don't feel like that I used to. And unfortunately, I don't have the previous functioning to compare, but often it really means different things to different patient. It could be attention is getting worse, or it's just slow in processing information, or you're simply tired, right? Or it might be depression. So it's really, I always try to listen to how it's described, and really look at and getting into what that really means to individual patient and make recommendations based on that. I think it's because there are significant individual differences in presentation and underlying mechanism that may be interfering with that. So
I also want to remind you to make sure that you're letting us know about those symptoms. That's a big thing. I mean, we will ask you all those questions in your visit, but if you're not sharing that you're having incontinence or you're having fatigue or anything like that, we may ask you about those things, but if you're not sharing those and having that open communication, then we're not able to help you with some of those symptoms.
I'll just, before we end, step briefly outside of my moderator role as a neurologist and just say that, I think oftentimes there are probably two ways that we go about addressing many of the symptoms. And the first thing are, there are a variety of non-pharmacologic, non-medication approaches to managing symptoms. And so oftentimes we'll review with you how well you're sleeping, because if you don't sleep, it turns out you can't think straight the next day. That's kind of a part of it. But once we investigate that and make sure that that's not really what's contributing to symptoms, we may suggest medications. And the one important thing that I would just like to impress upon everybody is there are no clinical trials to say that the best medication to manage pain in NMO from myelitis attacks is this medication. We just don't have that. We have a lot of medications, and sometimes there is a trial and error approach that has to take place. So I guess I would just encourage everybody that sometimes the first medication doesn't work for you. It may have worked for somebody else, but sometimes certain medications work with some people and not with others, and there is that process that may have to play out. So thank you. And we have one other question, I think, in the back, or actually on the side too.
So, Dr. Hutto and the panel, thank you very much for bringing this to a close. Excellent review. My name is Todd Burks with Amgen, and I've not said anything, but I've been taking a bunch of notes from everybody that's spoken today. We've had young patients find their voice and speak up. We've had gym teachers speak up. We've had a mom say, we've listened to a video, but that's not going to be our story. We're going to write our own story. And I'm trying to think, what do I want to share today to people that came here? Maybe you had a burden. You know, I've been in MS for neurology for, like Mitzi would say, a mature 25 years, but in rare disease, only 3. And the obstacles and the challenges that we see patients fight in rare disease is different than MS because 16,000 people have rare disease. When it comes to MS, it's 2.9. So when it comes to marketing and marketing dollars, you're going to see more go to MS. So on a Sunday, this outcome and how many clinicians came today on the back of the annual AAN in Atlanta, it makes me proud that I'm here. I'm part of industry, and when I hear patients be vulnerable talking on that stage to help other people have their fight be easier than their fight, that means that we're kind of making progress. I also want to say I'm grateful for 2014, somebody having the backbone, the intestinal fortitude, and a leap of faith to be diagnosed with a disease where there were no resources. And she says, you know what? I'm going to make a resource because to me, my dad told me the definition of success is not what you live, where you live, how big your house is, how nice the car you have. It's what do you do with your success in your health journey to make other people's journey easier. And I'm telling you what, I thank God that Sumaira in 2014 started the Sumaira Foundation, because if she didn't do that, today, this Sunday, is not happening. So I think we owe a hand to Sumaira from the Sumaira Foundation. And I have one final quote that I would like to read that I think embodies her and why we're all here today. And it's this: the ripple effect emphasizes the ideal that behavioral actions are not isolated events, but rather have the potential to influence a wide range of outcomes. So Sumaira, God made you and he broke the mold. You've assembled a team that is a force that can't be reckoned. And people that came to that door today, if your burden was heavy, when you leave, it should be lighter, because you now have people, you have phone numbers, you have physicians, you have scientists. It's hard to fight a bully alone, but together you can knock them out. And that's NMOSD and that's MOGAD. Thank you for coming, Sumaira.
We had one other question in the corner here. Thank you so much for sharing that. That was really wonderful. I don't think anybody could have closed us better.
I don't know how to quite follow that, but anyway, my question was that, so when a person is diagnosed with that, say a child is diagnosed with that, shouldn't the whole family come to one of the appointments, you know, with the doctors and the nurses and the therapists and everybody, so that their team could be up on what's needed for that person? Do you all suggest that?
It would be nice if they did. But the main thing is to educate the people who are present in everyday terms, not using fancy words, but to give them the expectation of what the treatments are going to be like. I even told parents, you may get a denial on this drug. Don't panic. You'll get the letter, but don't panic. I've got this. But the main thing is that well, with our patients, they know they can call me anytime. I don't care if a dad calls me, a grandmama calls me. I will talk to them. I just, the thing is to educate the people who are present enough that they know enough to go back and be able to tell the rest of the family without going home and saying, oh, they used a bunch of big words and we have no clue. So, we do try to kind of lay out what the plan of care is going to be. So.
Perfect. Okay, so I think we'll close the panel here, and I just want to say how thankful I am for all of the panelists joining me up on stage today to talk about these questions, very important questions, and what takes place next. Samara.
We're done. Thank you all.
Todd. I was just thinking that this was the first patient day I didn't cry at. And then we have Todd Burke. Where did it even go? Oh, Todd making me cry like that. Thank you. That's so nice of you to say. 10 years later, after 10 years of living with the disease, but 10 years of also doing this work, I have realized so much, and I have been thinking about so much. I've been reflecting a lot. And sometimes along this 10-year journey, I've been so angry about all of this. I wanted to be an actress in my life. I never thought I would be, living with a rare disease and doing nonprofit work and talking about science. I mean, I was never a science person. But then I have moments like this and this entire weekend in Atlanta where it all makes sense and it all is so worth it. The hard work is so worth it. The blood, sweat, and tears that I have put into this for the last 10 years, it feels so worth it when I see, patients like Sydney and Eliza and Jayla and Avery and Mimi and CG coming up here and their parents and the doctors, all of you. It's just, thank you for making this work so rewarding for me and for giving me inspiration to keep going and going. And, I don't do this alone. I was doing it alone for a long time, but I have a great team. We are a great team. And I just want to acknowledge Jill Sharp, our chief of staff, who has done so much to make this event happen. Michael Devlin, we call him my partner in cause, but he's the member of our strategic board, and he's been so helpful over the last 3.5 years. Jasmine Patel, who's a member of our leadership team. Thank you, Jasmine, for being here from San Diego. Alana Yee, who is directing our research initiative. She's here from Edmonton, Canada. And of course, all of you. Thank you to our sponsors. Amgen, Alexion, UCB, your support is everything, and our friendship means so much to me. Thank you to Dr. Grace Gombolay, Dr. Spencer Hutto, Dr. Mitzi Joy Williams for collaborating with us on this very, very special day. Every time we have a patient day, I'm like, oh, this one was my favorite, this one was my favorite, actually. So my birthday is on Wednesday, and this was the best gift I could have gotten. So thank you for being a part of this journey with me over the last 10 years. And I'm very, very curious and excited to see what the next 10 years hold. And thank you for coming on a Sunday and spending the day with us. I hope you learned a lot. I hope you made new friends. I hope you're excited about the future. I hope you look into all of the different options you have. And please take these flowers home. We have some extra unicorns. We'll take pictures outside. And any of you youngins or oldies who want to be part of the TikTok, come on over. We're going to do it. Thank you so much. Thank you.